So, I want you to just close your eyes for a second.
Okay.
Yeah, just shake off whatever you were doing before you hit play on this deep dive. Forget about the pharmacology flashcards or that care plan that you have due tomorrow.
Leave it all behind.
Exactly. I want you to picture yourself in the emergency department. You've got your scrubs on, stethoscope around your neck. It's a Tuesday. Maybe you're, grabbing a coffee, chatting with the charge nurse about the schedule.
It's a Norno rhythm.
Right, the beep of the monitors, the smell of antiseptics, standard stuff.
It's the calm before the storm. Because that comfortable routine is, well, it's about to shatter.
It really is, because suddenly the radio at the nurse's station crackles, and the voice on the other end isn't calm, it's screaming.
Oh, yeah.
They're saying, explosion at the stadium, multiple casualties, inbound, ETA 3 minutes. And just like that, the doors burst open. But it's not one patient with chest pain. It's not a car accident with 2 people. It is a wave of humanity. 50 people, maybe 100. Bleeding, screaming, unconscious. And here's the kicker, the part that kind of makes your stomach drop.
The rules.
The rules. The rules you have spent the last 2 years of nursing school memorizing. The ones that say, save the sickest patient first.
They just evaporated.
Gone.
That is the nightmare scenario. And it's not just a scene from some medical drama. I mean, it is the reality of Chapter 12.
Concepts of emergency and disaster preparedness.
Exactly.
Today, we are going completely off script from your standard MedSurg lecture. We're diving right into the chaos. We are taking the textbook, the Chapter 12 objectives, and that emergency student PowerPoint, and we are going to reconstruct your brain for disaster mode.
You have to, because
Yeah.
if you walk into that stadium explosion with a patient-centered mindset,
People will die.
they will. That sounds
Yeah.
harsh, but it is the absolute truth. The transition we are talking about today is the shift from patient-centered care to population-centered care.
Populations.
Yeah. And it is the single hardest mental hurdle for any nurse, whether you're a student or a 20-year veteran.
So let's lay it out for everyone. What is the actual mission for this deep dive?
Well, we need to rewire your critical thinking. For the NCLEX, sure, but also for real life. Think about it. In a normal shift, if a patient goes into cardiac arrest, what do you do?
You call a code, you swarm the room.
Right. You use every resource,
Yeah.
doctors, nurses, drugs, electricity, all of it, to save that one life.
Because that's the job. That's what we're trained for.
But in a disaster, if you do that, you have failed.
Wow.
In a disaster, the mantra changes entirely. It becomes the greatest good for the greatest number.
The greatest good for the greatest number.
Exactly. That means you might have to look at that cardiac arrest, look at the 50 other people bleeding out who actually could be saved.
And make the decision to walk away from the code.
You have to walk away.
Just saying that out loud, it feels wrong. It feels like a total violation of the nursing oath.
It feels like moral injury, and we're going to talk about that today. But to pass this exam and to function in a mass casualty incident, you have to understand the logic behind the math.
So we're going to break this down piece by piece for you. We'll start by defining the disaster, like what counts and what doesn't. Then we are going to spend a massive amount of time on triage.
The meat and potatoes of the exam.
The colors, red, yellow, green, black.
You need to know those cold. We will
Yes.
test you on them.
Absolutely. Then we'll get into the clinical skills, the bleeding control, the stop the bleed protocols from the PowerPoint. We'll look at the command structure.
Because you cannot be a lone wolf in a crisis.
Right. We'll talk about your go bag, evacuation protocols, and finally, the psychological aftermath.
It's a heavy topic, but a really necessary one.
So let's start at the beginning, section 1. Defining the crisis. I think for most of us, the word disaster implies something huge. An earthquake, a nuclear bomb.
Sure.
But in the hospital world, and specifically on the NCLEX, the definition is a little more technical, isn't it?
It is. The test is going to try to trip you up on the difference between a multi-casualty event and a mass casualty event.
Okay, let's parse that. Multi-casualty versus mass casualty. I mean, they sound completely synonymous.
They do, but the distinction isn't about the number of bodies. It's about the resources.
Resources.
That is the key word, resources.
Give me an example of how that works.
Okay, imagine a really bad pileup on the highway. Maybe a bus rolls over. You have 10, maybe 15 victims. They come into your level 1 trauma center. Is it chaotic?
Yes.
Is it stressful? Absolutely.
Mm-hmm.
But does the hospital have the staff and the blood and the beds to handle it?
A level 1 trauma center. Yeah, probably. They might call in a few extra people, but they can handle 15 patients.
Exactly. That is a multi-casualty event. The hospital can manage the crisis using local resources. You're stretched, but you aren't broken.
Okay. So when does it become a mass casualty event, an MCI?
When the demand exceeds the supply, an MCI is defined as an event that absolutely overwhelms local capabilities. It forces the hospital to collaborate with outside agencies, state, regional, national help.
So it's not a fixed number of patients, it's a ratio.
Precisely. Think about it this way. If you are a tiny, rural critical access hospital with one doctor and two nurses on night shift, and you get that same bus crash with 15 critical patients.
No, that's a mass casualty event for them.
Correct. Because they are overwhelmed. They cannot provide the standard of care for everyone. But for a massive university hospital, that same crash is just a busy Tuesday.
That makes a lot of sense.
On the NCLEX, look for clues about overwhelmed resources or need for outside assistance. That is your trigger for MCI protocols.
That is a crucial distinction for you to remember. It's relative to what you have in the bank. Now, the outline also splits disasters into internal versus external. This seems a bit more intuitive, but let's make sure we aren't missing any nuance here.
External is what we usually think of.
Yeah.
Something happens out there, out in the community, and the victims come to us.
Like the stadium explosion we talked about.
Right. Or Hurricane Ida, or the Pulse nightclub shooting, or the Las Vegas Harvest Music Festival. The hospital is the lifeboat, and the storm is outside.
And internal is when the lifeboat springs a leak.
That's a really good way to put it. An internal disaster is an event inside the healthcare facility that impairs your ability to function or endangers safety. The obvious ones are fires or explosions inside the lab. But the ones that really cripple a hospital are the utility failures.
Like losing power.
Losing power is bad, sure, but generators usually kick in for the critical stuff. Imagine losing water.
If the water main breaks.
Think about it. You can't scrub into surgery. You can't run the sterilization machines for the instruments. You can't run dialysis machines because they need massive amounts of treated water. You can't even flush the toilets.
Wow.
An internal loss of water effectively shuts down a modern hospital faster than a power outage.
I hadn't even thought about dialysis. That's an immediate life threat for those patients.
It is. And then there is the violence aspect, an active shooter in the lobby. That is an internal disaster where the priority shifts instantly to safety.
Meaning lock the doors, hide, run.
Meaning you are no longer treating patients, you are trying to survive. Priority is patient, staff, and visitor safety. But here is where the NCLEX gets tricky. Can you have both?
Can you have an internal and external disaster at the exact same time?
You absolutely can. And this is the combined event. The classic example we all just lived through is COVID-19.
How so? Walk us through that.
Well, it started as an external disaster. A pandemic in the community, waves of sick people coming into the ER. But then what happened inside the hospital?
The staff got sick. We ran out of PPE.
Exactly. The internal resources collapsed.
Yep.
Staff shortages, supply chain failures. So you had an external influx, overwhelming an internally compromised system.
Double whammy.
Another example. A hurricane hits, which is external, and the flooding knocks out the hospital's basement generators, which is internal.
That is the worst case scenario. You have people flooding in for help, and you are literally flooding out.
And that brings us to the core of today's discussion. When you are in that situation, when the stadium has exploded or the hurricane is hit, and you have 100 patients and 5 nurses, how do you choose who lives and who dies?
Triage.
Disaster triage.
This is section 2, the core of the NCLEX, the meat and potatoes. Listeners, if you are multitasking right now, come back to us. This is where the points are in your exam.
And more importantly, this is where the clinical mistakes happen. Because disaster triage is not emergency room triage.
Let's clarify that. In civilian triage, regular ER day-to-day, who gets seen first?
The sickest patient, the person having the massive heart attack, the person with the gunshot wound to the chest. We take the absolute most unstable patient and we throw everything at them.
But in disaster triage, we are using the military model.
Yes. The goal is the greatest good for the greatest number. We are allocating scarce resources. So if I have 1 hour of surgeon time, do I spend it on one person who has a 5% chance of survival? Or do I spend it on 4 people who have an 80% chance of survival if I act right now?
You save the 4.
In a disaster, yes. In a normal ER, you try to save the 1. That switch is what freezes people. So let's get into the colors. The tag system.
Okay, we're going back to our stadium. The explosion just happened. Dust is everywhere. You're the first triage nurse on the scene. You have a stack of tags in your pocket. Red, yellow, green, black. Let's walk through the crowd.
Let's do it. You see a young man. He's clutching his throat. He's gasping. He has stridor, that high-pitched sound of a blocked airway. He's turning blue. What color is he?
My gut says he's dying. He needs help right now.
But is he treatable?
If I open his airway, yes.
Then he is red. Class I. Emergent.
Okay, so red isn't just dying. It's dying but fixable fast.
Bingo. That is the distractor on the test. Red tags are for immediate threats to life, like airway, shock, uncontrolled bleeding. They can be corrected with rapid intervention.
Rapid intervention.
If you can fix it in the field or with a very quick surgery, they get a red tag.
Okay, so this aligns with the Save a Life flowchart in the PowerPoint. It emphasizes massive bleeding here, too.
Yes. If someone has a severed femoral artery and is bleeding out, they will die in minutes. But if you slap a tourniquet on, you save them. High bang for your buck, red tag.
Okay, next patient in the rubble. A woman is sitting against a piece of concrete. She has a compound fracture of her tibia. The bone is sticking out through the skin. It looks horrific. She's in a lot of pain. She's asking for meds. But she's talking to you. And her pulses and her foot are present.
What's your instinct?
The bone is sticking out. That feels super urgent.
It is urgent. But is she dying right now?
Well, if she has a pulse and isn't spraying blood everywhere, no.
Correct. She is yellow. Class 2.
Yellow means wait.
Yellow means major injuries that need treatment within 30 minutes to 2 hours. She needs surgery. She needs antibiotics. That leg is an absolute mess. But if she waits 45 minutes while you intubate the guy with the crushed airway, she will still be alive.
This is a huge trap for students. We see a grotesque injury, a bone literally sticking out, and we panic. We want to fix it. But the vital signs tell the truth. Stable vitals usually equals yellow.
Generally, yes. If they are hemodynamically stable but have a major injury like large wounds or open fractures with distal pulses, they are yellow. They can hold.
All right, patient number 3. A guy is walking around the perimeter. He's covered in dust, maybe some blood. He's holding his arm, looks like a sprained wrist, maybe some minor cuts on his face. He's screaming at you, "My friend is in there, help him!"
He's walking, he's talking, he is green.
Class 3, non-urgent, the walking wounded.
Exactly. These are minor injuries. Abrasions, contusions, sprains. They can wait hours.
But the sources warn us about these green patients. They aren't just harmless background characters in this scenario. Why are they a problem?
Think about human nature. If you are hurt and scared, and the ambulance isn't coming fast enough, what do?
I get in my car, or I hop in an Uber.
And you go straight to the hospital. The walking wounded often self-transport. They arrive at the ER before the ambulances bringing the reds and yellows even leave the scene.
So the ER gets flooded with 50 sprained ankles.
And they clog the triage desk, they take up the beds, they use up the staff. If the hospital isn't careful, they are overwhelmed by green tags and have no physical room or personnel for the red tags when they finally arrive.
That is a massive logistical nightmare. And there was a point in the reading about contamination too, right?
It's a very important point. If the disaster was chemical, say a chlorine gas leak, and these people self-transport without getting decontaminated first, they walk right into your waiting room carrying the toxin on their clothes. Now your ER is a hazmat zone.
So wrangling the greens is actually a huge safety priority for the incident commander.
You have to corral them, put them on a bus, keep them at the scene. Do not let them flood the zone.
Okay. We have red for immediate, yellow for urgent but stable, green for walking. Now we have to talk about the one that keeps nurses awake at night, the black tag.
Class 4, expectant.
Let's go back to the rubble. You find a patient. Massive head trauma. Brain matter is visible. They are unconscious. Their breathing is irregular and slow, agonal breathing. But they have a pulse.
In a normal ER, we would be intubating, scanning, calling neurosurgery immediately.
But in the stadium.
In the stadium, you tag them black.
Even with a pulse.
Yes. And here is the why that you need for the exam and for your conscience. That patient requires a ventilator, a neurosurgeon, an OR suite, and probably 20 units of blood to have maybe a 1% chance of survival.
And those resources?
Those resources are gone. If you give all that to this one patient, the 3 people with red tags, the ones with the treatable chest wounds or the shock, they die because you were busy.
So you are basically sacrificing the one unlikely survivor to save the 3 likely survivors.
It is the brutal math of disaster. Black tags are for the dead or those with injuries so severe that survival is unlikely given the resource scarcity. High cervical spine injuries with no breathing, 90% full-thickness burns, massive open head trauma.
Does black tag mean we just abandon them completely? Do we literally just walk away?
Well, triage means to sort. You sort them and move on. If you have extra staff later, or if palliative care teams arrive, you provide comfort measures. You don't let them suffer if you can help it. But you do not expend life-saving resources on them until all the reds and yellows are entirely handled.
I can see why the sources talk about moral injury. It goes against everything we are trained to do.
It does. And on the NCLEX, they will test your resolve on this. They will give you a patient description that sounds heartbreaking. A 6-year-old child with massive head trauma, GCS of 3, agonal breathing. And they will ask you what color tag to apply.
And every fiber of your being wants to say red because it's a kid.
But the answer is black. Because if you try to save that one child, you might lose 10 other children who could have easily been saved.
Phew. Okay, that is tough, but we absolutely have to know it. Now, to make these calls, we have to assess fast. We aren't doing a 20-minute admission interview. The student PowerPoint lists a primary assessment.
Speed is the name of the game here. You are doing a 15-second assessment per person.
What are the tools we're using for that?
AVPU is the classic.
AVPU. Break that down for us.
A is for alert. Are they looking at you? V is for verbal. Do they respond when you yell, "Can you hear me?" P is for pain. Do they flinch if you pinch their shoulder or do a sternal rub? And U is for unresponsive.
So if they are alert, they probably aren't black. If they are unresponsive,
You check a pulse, open the airway once. If nothing happens, they are black. Move on.
the slides also mention the Glasgow Coma Scale, or GCS.
GCS is great. It's very detailed, but AVPU is faster in the mud and blood. The other key part of the assessment is exposure.
Which meant
Cutting the clothes off. You cannot triage what you cannot see. You might think someone is just in shock from a broken arm, but they actually have a gunshot wound to the back. You have to strip them to find the life threats.
But there are two big caveats here, right?
Yes. One is hypothermia. Trauma patients lose the ability to regulate their body temp. If you strip them naked in a parking lot, they will freeze and go into irreversible shock. You have to cover them back up immediately.
And the second caveat is the legal one.
Forensics. If this is a crime scene, like a bombing, a shooting, a rape, the clothing is evidence.
So you don't cut through the bullet hole?
Never cut through the bullet hole or the stab wound. You destroy the pattern evidence. You cut around the seams. And don't throw the clothes in a pile on the floor. If possible, put them in a paper bag.
Why paper?
Plastic traps moisture. Wet, bloody clothes in a plastic bag will mold very quickly, destroying DNA evidence. Paper lets it breathe. Nurses are the first link in the chain of custody for evidence.
That is a major pro tip right there. Paper bags for evidence.
Okay, let's move to section 3. Clinical management. We've tagged them. Now we have to actually do something for the red tags. The PowerPoint focuses heavily on stop the bleed.
Uncontrolled hemorrhage is the #1 cause of preventable death in trauma. If you can stop the bleed, you save the life.
So what is the hierarchy? I see blood. What is step 1?
Step 1 is not touch the patient. Step 1 is ensure safety.
Yours.
Yours, first and foremost. If the shooter is still active or the building is still collapsing, you do not run in.
The dead hero rule.
Exactly. A dead nurse saves 0 patients. A wounded nurse becomes another patient that requires resources. You must ensure the scene is safe before you engage.
Okay, scene is safe. I see a leg wound spurting bright red blood. Arterial, what do I do?
Direct pressure
Yeah.
immediately. Use a clean cloth if you have it, or just your gloved hands, and lean on it. I don't mean a polite, gentle touch. I mean, put your body weight into it. It should hurt the patient.
And if it bleeds through the cloth? Add more layers. Put a pressure dressing on it. Elevate the limb above the heart if possible to slow the gravity flow.
Okay, I'm pushing, but it's still soaking through. It's a garden hose of blood.
Then you escalate to the tourniquet.
Now, I feel like tourniquets went through a phase a few years ago where they were considered bad. Like, oh, you lose the limb if you use one.
That was the old teaching. The new science, which is heavily driven by military experience, says life over limb. The text describes the tourniquet as a last resort for uncontrolled hemorrhage, but do not hesitate if pressure fails.
Where do I put it?
High and tight, or at least 2 to 3 inches above the wound. Never over a joint. You tighten the windlass until the bleeding stops, and this is crucial, the distal pulse disappears.
That is going to be excruciating for the patient.
Yes, you tell them this is going to hurt, but it will save your leg. And once that tourniquet is on, listener, please pay attention to this. Do not take it off.
Not even to check if it stopped bleeding.
Never. The student PowerPoint is explicit about this. Keep the tourniquet in place until the patient is in the operating room. Removing it in the field can release built-up toxins and restart the bleeding, causing immediate shock.
Leave it for the surgeon. Got it. Speaking of shock, what else are we doing for these bleeding patients?
Position them supine, which means flat on their back. Legs up is debatable in some new research, but supine is the standard answer. Keep them warm. And we need fluids.
just normal saline.
In a true massive hemorrhage, saline just dilutes the remaining blood. We need packed red blood cells, PRBCs. We need to replace what was lost, which is the oxygen carrying capacity.
Okay, so we are stopping bleeds, we are tagging patients, but who is orchestrating this chaos? If 50 nurses show up, who tells them where to go? This brings us to Section 4, the command structure.
The HICS, Hospital Incident Command System.
It sounds a bit bureaucratic, but without it, you just have a mob of well-meaning people running into each other.
Exactly. HICS is a federally mandated organizational structure. It creates a very clear chain of command.
Let's meet the cast of characters. Who is the big boss?
The Hospital Incident Commander.
Now, in my head, this should be the chief of trauma surgery or the head of the ER. They know the medicine best, right?
And that is a huge misconception. The incident commander is usually a high-level administrator or a senior physician, but their role is not clinical.
Wait, the person in charge isn't treating patients.
If the commander is intubating a patient, they have tunnel vision. They're looking at one airway. They aren't looking at the fact that the generator just died or that we are out of O-negative blood or that CNN is at the front door.
So the commander needs a global view.
Correct. They manage the system. They hold the authority to activate the disaster plan and allocate resources. They're the conductor. They don't play the instruments.
Okay, so who handles the medicine part?
The medical command physician. They determine the medical needs, like we need more surgeons or we need to open the PACU as an overflow ICU.
And the person at the door?
The triage officer. This is the gatekeeper, usually a physician or a very experienced nurse. They stand at the ambulance bay and look at every single patient. You go to shock trauma. You go to the waiting room. You go to the morgue. They have to be incredibly decisive.
Now, there is one role that has a very specific nursing safety priority attached to it in the text, the Public Information Officer, or PIO.
This is huge for students. In the age of social media, this is an absolute minefield.
Let's do a scenario. You are a nurse. You just walked out of the ER covered in soot. A reporter with a camera shoves a microphone in your face. What's happening in there? How many dead? Did you see the mayor's son?
Your instinct is to answer, to be helpful, to share the horror of what you just saw.
But the correct answer is?
Please speak to the Public Information Officer. And you keep walking.
Why can't I just say it's really bad in there?
Because you might accidentally violate IPAY. You might spread a rumor that turns out to be false. You might confirm a death before the family is notified, which is devastating. The PIO's job is to release accurate, verified information to the media and the public.
So stay in your lane.
Protect your license. Protect the families. Don't talk to the press. Direct all inquiries to the PIO.
Okay. Section 5, the nurse's role in preparedness. We've talked about the hospital's plan. What about your personal plan?
The text is very clear on this. Preparedness starts at home. You cannot help anyone if you are a victim or if you're paralyzed by worry about your own family.
This is the classic put your own oxygen mask on first rule.
Exactly. The text suggests every nurse needs a go bag or a survival kit.
Let's raid the bag. What's in it? This is box 12.2 in the text.
Water.
Yeah.
And not just a water bottle. 1 gallon of water per person per day.
1 gallon. That weighs over 8 pounds.
It's heavy. But you need it for drinking and hygiene. And you need a 3-day supply minimum.
So for a family of 4, that's 12 gallons of water. That takes up a lot of space.
It does. But dehydration kills fast. Next up is non-perishable food. And a flashlight.
And specifically a headlamp, right?
Yes. Why do you think that is?
Because nurses need their hands. You can't start an IV or hold pressure on a wound while holding a mag light.
Exactly. You also need a battery-powered radio for news. Medications, do not forget your own prescriptions. Cash, because ATMs don't work without power. And sturdy footwear. Do not try to evacuate in your Crocs.
But it's not just physical stuff, is it? It's the family plan.
This is the part people always forget. If a pandemic hits, or a hurricane, schools close, daycares close. If you are ordered to work a 16-hour shift, who is watching your kids? Who is checking on your elderly mom? Who is feeding the dog?
If you don't have that answer now on a sunny Tuesday,
then when the disaster hits, you won't show up to work. You will stay home to protect your family. That is the ethical conflict the text discusses, the struggle between professional duty and personal safety.
we saw this a lot with COVID. Nurses were terrified of bringing the virus home to their kids.
It's a very valid fear. Preparedness minimizes that conflict. If you know your family is safe and supplied, you can actually focus on your patients.
Now let's talk about floating. In a disaster, the nice structured units just dissolve.
Professional flexibility is required. If the ER is grounding, they might pull nurses from everywhere else in the hospital.
The text gives a few examples. A GI lab nurse doing conscious sedation in the ER, an ortho nurse pushing stretchers to radiology.
Right.
But here is the fear. I am a med-surg nurse. I don't know how to run a ventilator. If they float me to the ICU during a pandemic, am I going to lose my license if I make a mistake?
This is a really common anxiety. The rule is you can float, but you must remain within your scope of practice.
Explain that for us.
You are a nurse. You know how to assess, give meds, document, do basic hygiene. If you go to the ICU, you might not manage the complex vasoactive drips or the ventilator settings, but you can bathe the patient, give the oral meds, empty the Foley, and turn them. This frees up the ICU nurse to handle the critical tech.
So you become a force multiplier. You handle the basics, so the specialist can handle the complex.
Exactly. You are there to help, not to be a cowboy. If you are asked to do something you don't know how to do, you have to speak up. I am not trained on this device. That is safer than guessing.
One more specific scenario in this section, evacuation. Let's say the disaster is a fire, the wing is burning, we have to get patients out. Who goes first?
Now, in a normal day, you help the sickest first. In a fire evacuation, you completely reverse it. Priority 1 is ambulatory patients. Priority 2 is wheelchair or assistance needed. Priority 3 is bedbound or stretcher patients.
Wait, we leave the bedbound patients for last, the ones who literally can't move.
It sounds cruel, but think about the physics of this situation. You have smoke filling the hall, you have 20 patients. 15 can walk, 5 are bedbound. It takes one nurse 30 seconds to yell, "Everyone who can walk, follow me," and lead 15 people to safety.
Right.
But it takes 4 nurses 5 minutes to drag one bedbound patient out.
So if you spend your time on the bedbound patient first,
The 15 walkers might die of smoke inhalation while waiting for you. You clear the easy ones first to save the maximum number of lives quickly. Then you come back for the hard ones.
greatest good, greatest number, it just keeps coming back to that.
It does. Also, quick safety tip for fires. Oxygen?
Oxygen feeds fire.
Shut it off. Unless the patient will die instantly without it, you turn off the wall oxygen for everyone before you evacuate. If they are ventilator dependent, you bag them manually with room air if possible, or use a portable tank if strictly necessary, but you have to cut the main supply.
Okay. Section 6, special hazards. We can't ignore the invisible threats. Bioterrorism and pandemics.
The text mentions anthrax specifically, but the principles apply to any chemical or biological agent.
Let's do a scenario. A subway attack. Sarin gas. People are rushing to the hospital. What is the golden rule of decontamination?
Decontamination happens outside.
Do not bring the patient in.
Never. If a patient covered in sarin gas walks into the ER is now contaminated, the staff gets sick, the other patients get sick, the hospital shuts down.
So you set up a tent in the parking lot.
Yes, a designated decontamination area. Hose them down, strip the clothes, which is where 80 to 90% of the contaminant usually is, and wash them with warm water and soap. Only when they are completely clean do they enter the clean zone of the hospital.
And the staff doing the washing?
Level C or higher PPE, hazmat suits. You cannot do this in standard scrubs.
And moving to pandemics, we have two words that get used interchangeably all the time, but for the exam, they are very different. Quarantine and isolation.
Very different. Isolation is for people who are sick. We isolate the infected to contain the bug. Quarantine is for people who've been exposed but aren't sick yet. We watch them to see if they turn into patients.
So if I have COVID, I am isolated. If I sat next to you and you have COVID, I am quarantined.
Correct. And in a pandemic, we use surge strategies. We saw this with tents and parking lots, converting cafeterias into wards, and canceling elective surgeries.
Why cancel elective surgeries?
To free up staff and beds. That knee replacement can wait. The ventilator and the anesthesiologist need to go to the viral pneumonia patient.
Okay. We have survived the explosion, the fire, and the plague. Now comes Section 7, resolution and the aftermath. The dust settles. Who decides it's over?
The incident commander issues the stand-down order.
Does stand down mean we just turn off the lights and go home?
No, actually,
Oh.
This is a very dangerous time. Staff are exhausted, supplies are depleted. You cannot resume normal operations until you have verified that you have restocked the shelves and rested the staff.
You can't do an open heart surgery the next morning if the surgeon has been awake for 36 hours.
Exactly. Safety first.
And then comes the processing, the talking, the debriefing. The text distinguishes between two types. This feels like a classic test question. CISD versus hot wash.
It is. You really need to know the focus of each. First is Critical Incident Stress Debriefing, or CISD. Crisis support. The focus here is emotional.
This is the how are you feeling meeting.
Yes. Small groups of staff, facilitated by a mental health professional, discussing feelings, coping mechanisms, venting. The goal is to prevent PTSD and help people process the horror they just saw.
And the second type, the hot wash or administrative review.
The focus here is systems. It's not about feelings, it's about facts. What went right? What went wrong? Why did the radios fail? Why did we run out of morphine?
So saying, I feel sad about the child who died is for the CISD. Saying, we need more pediatric crash carts is for the hot wash.
There you go. Don't mix them up on the exam.
Finally, let's talk about the toll this takes on the nurses, the psychosocial impact. The text mentions PTSD, acute stress disorder, and burnout.
The difference between acute stress disorder, or ASD, and PTSD is largely time.
What's the cutoff?
1 month. If you are having flashbacks, severe anxiety, dissociation, and numbness within the first month after the event, it is acute stress disorder.
And if it goes past that?
If those symptoms persist after 1 month, or if they start months later, it is PTSD.
Is there a tool to measure this distress?
The Impact of Event Scale Revised, IESR. It's a questionnaire. If a nurse scores high on this, they need a referral to a mental health specialist immediately.
And what about burnout?
That's the slow erosion, emotional exhaustion, depersonalization, feeling like you just don't care anymore because the tank is completely empty. It's a huge risk in nursing, especially after prolonged disasters like a pandemic.
Wow. We have covered a massive amount of ground today, from the definition of an MCI to the specific color of the triage tags to the legalities of evidence collection.
It's a lot of material, but it's vital for the NCLEX.
Let's do a quick lightning round to solidify it. I'm going to throw a concept at you, and you give me the NCLEX takeaway. Ready?
Ready, let's do it.
Triage tag. Patient gasping for air. Treatable.
Treatable.
Triage tag. Broken leg, screaming loudly, pulse is okay.
Yellow. Don't let the scream fool you.
Triage tag. Walking around the scene asking for a cigarette.
Green. Keep them out of the ER.
Triage tag. Massive head injury, agonal breathing, pulse present.
Black. Save the resources for the reds.
Where is the incident commander located?
The command center, not the bedside.
You're a nurse and a reporter puts a microphone in your face.
Talk to the PIO. Zip your lips.
Where does decontamination happen?
Outside. Protect the clean zone.
Evacuation priority in a fire.
Walkers first. Bedbound last.
I feel like we have armed the listeners with a shield and a sword for this topic.
I hope so. They should be ready for the exam.
Before we go, I want to leave everyone with a final thought. We've talked a lot about rules and colors and logistics today, but underneath all of that is the moral weight.
The black tag.
Yeah. As you study this, don't just memorize the color. Picture the moment. Ask yourself if you are truly ready to stand in the chaos. Look at a human being who is still breathing and make the decision that saving them costs too much.
It is the hardest thing you will ever do. You have to remember, you aren't doing it to be cruel. You are doing it so that the person next to them, the one with the treatable wound, gets to go home to their family. That is the burden and the honor of disaster nursing.
Take a breath. Go review that Save a Life flowchart one more time. You can do this.
Good luck with your studying.
Thanks for joining us on this deep dive. We'll see you on the next shift.